I'm Mary Lovely, Chair of the International Relations Program. Welcome to the first event of a two-day celebration of International Women's Day 2015. Our theme this year is celebrating women who serve in combat and post-combat zones. These events were organized with a wide variety of people, and the first person, of course, is I'm going to introduce in just a minute, Professor Bob Moret. We're very excited to be partnering with folks outside of Maxwell this year, and we'd like to express our appreciation to the organizations that we have partnered with, amazing organizations, progressive and very proactive in dealing with some of the issues we're going to talk about over the next couple of days. They include the Veterans Affairs Medical Center, Institute for Veterans and Military Families, and the Office of Veterans and Military Affairs at SU. I want to extend my deepest thanks to the highly skilled staff in all these institutions, as well as to the amazing staff in the International Relations Program, the ICT group who are doing our technology for us today, and in Arts and Sciences, especially their communications group. My deepest thanks to all of you. This doesn't just happen. It takes a lot of people working together. Today's event will be live streamed. The streaming address is on our website at maxwell.syr.edu. We will be taking questions via the web when we get to our question and answer session. I want to thank Bob Moret for suggesting that we contact people at the Veterans Affairs Medical Center. Like so many people who feel that they are supportive of the troops and returning veterans, I was ignorant. And I've learned a lot over the last month about the needs of women veterans. We're going to talk tomorrow about the needs of other women who serve in combat and post-combat zones. And I've become educated about those issues as well. Many of those people, of course, are our students, and SU graduates have gone on and are doing amazing things all over the world, oftentimes putting themselves in harm's way to make life better for others. So we want to honor their service and also think about what's the best way to train them, support them while they're there, and then to welcome them home and really help them integrate back into civilian life. I have learned that one of the top issues for returning women is gender-specific health care, such an important issue for women after service. And so I feel very honored that we have such a high-level panel here today. And I'm going to turn the mic over to Bob Moret to introduce our group. Bob Moret is Deputy Director of the Institute for National Security and Counterterrorism, and he's a professor of practice here in the Public Administration and International Affairs Department. And he's been a wonderful partner in organizing these events and a great supporter for the VAMC. Bob?
Thank you, Mary. It's good to see you all here this afternoon to draw attention to something that cannot have more attention, which is the medical care and the assistance and all the aid that we provide for our veterans and especially their families and the men and women, with an emphasis on the woman, that makes such a difference. As I tell people just briefly, one of the things that we're proudest of here at SU is that our Veterans Institute is the Institute for Veterans and Military Families. And those of us that have been in the business understand that families are the connective tissue that enable our military service, and it's great to see that recognized here today. I actually won't be introducing the whole panel. I'm going to introduce Dr. Judy Heyman and ask her to introduce the other members. But I would like to do a brief introduction on Dr. Heyman, who we have worked with for more than 4 years now in terms of collaborative efforts between the Maxwell School and other parts of the university and the VA Medical Center. I'll speak about her, and then I'll speak about the medical center itself just briefly. Dr. Heyman is the Associate Medical Center Director at the Syracuse VA MC. She is responsible for day-to-day management of facility operations, resource management, and working collaboratively with staff to improve overall quality. Some comments on that in a second. Veteran satisfaction and access. Previously, Dr. Heyman has been the Behavioral Health Care Line Manager since January 2008 and served as the Polytrauma Network Site Psychologist beginning in July 2006. Dr. Heyman received her PhD in clinical psychology from Fairleigh Dickinson University, completed her internship, I'm sure some hard lessons learned, at the Kings County Hospital Center in Brooklyn, New York, and a one-year fellowship program in rehabilitation medicine and neuropsychology at the Mount Sinai Hospital, also in New York City. She also has previous experience in business management and administration. In addition to being the Associate Medical Center Director, Dr. Heyman was also the acting director of the entire hospital for a period of nearly 6 months. Recently, when Jim Cody, the Medical Center Director, was called upon to run one of the large areas under the responsibility of the VA. For both of them, and the panel that you see on my left up here, we should recognize, especially in light of a lot of recent press accounts we've had on the VA, that this VA Medical Center here in Syracuse is truly extraordinary. As many of you know, there are 152 VA medical centers in the United States. Just recently, this one was ranked number 1 of 152 in patient satisfaction. It is truly a remarkable center, and it's the people over there a lot of us have seen from firsthand experience that makes such a difference. So with that as the theme, please join me in welcoming Dr. Heyman to the platform.
Thank you. I'd first like to thank Bob and Mary for the lovely invitation. We're thrilled to be here, and the very nice remarks about the Syracuse VA. It's exciting to be part of the celebration of International Women's Day. The slide doesn't seem to be working. Sponsored by the Maxwell School and the Institute for Veterans and Military Families. So I'd like to start by asking any veterans in the audience to stand up or raise your hand. I know we have many. Thank you for your service and dedication to our nation. Oop, it's a very quick button. I'll be providing just a very brief overview about the Department of Veterans Affairs. Then we'll have some information about the Women's Health Program and working with post 9/11 veterans and the new generation of returning women veterans. Then the second portion of our panel is from the veteran perspective, and we have a wonderful panel of 4 people from different eras of service that will give you some insight into their shared and unique experiences as women in the military. So you're probably familiar or have heard at some point President Lincoln's original charge to care for veterans. So that's our mission, and VA employees feel very strongly affiliated with the mission. Just a few little logistical stats. We're the second largest cabinet agency, second only to the Department of Defense. The Department of Veterans Affairs is broken down into 3 administrations: the Veterans Benefit Administration, the National Cemetery Administration, and our portion, which is the Veterans Health Administration. So just very briefly, the Veterans Benefits Administration, which you probably already gathered, is the benefit arm of the VA, and this is some of the examples of benefits that they provide, and it's certainly not a comprehensive list, but there's lots of unique benefits available for those who have served. The National Cemetery Administration is probably pretty self-explanatory as well. So they provide veterans with resting places and memorials. On to the Veterans Health Administration, which is the portion that all the medical centers fall under. We, as I mentioned earlier, very strongly affiliated with our mission. We are the largest integrated health systems network in the country and one of the largest in the world. The Veterans Health Administration has 4 statutory missions. The first one that people are probably most familiar with is the operation of a healthcare delivery system. Equally important are our mission of education, research, and service in national emergencies. I'll just mention that Approximately 60% of medical residents have received some training at a VA facility. Syracuse has numerous academic affiliations, and of course we have one with SU thanks to Bob Moret several years ago. The research mission is equally important, and the VA has been recognized for lots of groundbreaking research, and later on there's a list of resources, so if you have more questions, you can certainly look it up. It's pretty impressive. I think they have about 10 pages of accomplishments. And then probably one that maybe a lot of people are not aware of, we're called to serve in the event of a national emergency. So I just pulled a few things from some of the research in the education website. It's pretty impressive to me that we had 3 Nobel Prize winners. I didn't really know that until recently. Equally impressive, the pacemaker, the nicotine patch. I mean, these are things that everybody is well aware of and doesn't give a second thought to, and those came out of VA research. First liver transplant and the artificial limbs, and they continue to do a lot of research in prosthetics. So as far as for the healthcare portion, we have nationally over 288,000 employees. The VA has established years ago a targeted goal of hiring 33% of our employees should be veterans, and by 2014, I believe, we're looking to have 40% of veterans as employees. And you'll see that we've got several veteran employees here, not just on the panel, but also in the audience. So one of the things that's a bit unique about the VA is we offer a lifetime of care and a full range of services. This is a brief list here. Oftentimes the services that we're able to provide aren't always available to non-veterans in their communities. So that's one of the strengths, I think, of the VA. We also focus on issues that are related to service. So again, this is certainly not an all-inclusive list, but I do want to point out some of the things with rehabilitation. I think you could probably say inarguably that VA is a leader in prosthetics and sensory aids. And I will just give a plug to Syracuse. Out of the last 3 years, we have been twice awarded the National Service Award for prosthetics. So we're very proud of that accomplishment. Again, this is just an idea to give you some of the services that we have, certainly not all-inclusive, but I think the thing that Mary was mentioning, being proactive and leading edge, we focus on wellness and prevention and caring for the entire person. So that gives you some idea of the many services that we have. So I hope you found this brief overview informative, and hopefully it enhanced your knowledge of some of the programs at both the Department of Veterans Affairs and the Veterans Health Administration. So our next panel is going to be talking about services available within the VA, and then the second portion, you're going to hear 4 unique perspectives from women who have served. So it's my pleasure to introduce Dr. Mindy Grewal, who's the medical director of the Women's Health Program.
Thank you, Judy. So I would just like to start with kind of a brief, brief synopsis of what do we offer in women's health in Syracuse, VA. Before that, we'll talk about statistics. So on an average, women make about 6% of veterans in the catchment area for Syracuse, VA, so about 8,441 individuals. Jefferson County has the highest proportion of women veterans, with 12.7% of all veterans being women, so about 1,420. This actually comes from a study done by Maxwell. So it was done by demographic analysis of veterans in the Syracuse catchment area. So I thought I should acknowledge that. And this study was done in 2012. These are some national statistics that we have coming from U.S. Department of Veteran Affairs fact sheet, July 2014. So women comprise 14.5% of all active duty military at present. 18% of National Guard and reserves, 6.8% of VA healthcare users. So that gives us some idea where we will be in the next few years and how much we need to do to provide services for women veterans. Since 2000, the number of female veterans using VA healthcare has more than doubled from nearly 16,000 in 2000 to more than 390,000 and in 2013. So this growth rate has outpaced that of male veteran population by a large margin. Among women veterans returning from current conflicts, which is OEF, Operation Enduring Freedom, Operation Iraqi Freedom, and Operation New Dawn, 81.1% were born in or after 1970, which is age 43 or younger. 54.6% were born in or after 1980, age 33 or younger. So that gives us a perspective of what kind of care they will be needing, including maternity care, because many of these women are in childbearing age. 59.7% of female OEF, OIF, and OND veterans have received VA healthcare. So of this group, 90.6% have used VA outpatient services more than once, and 57% have used them 11 or more times. That means they are, primarily using VA healthcare services. Okay. So location of our clinical services within the VA in Syracuse and the surrounding areas. So we have different options. We have the Women's Health Wellness Center, which is located here at Syracuse VA. Then we have our primary care teams, Team Blue, Team Red, and some of our female veterans also are there for primary care. Then we have community-based outpatient clinics. We have 7 community-based clinics: Rome, Binghamton, Auburn, Cortland, Freewell, Messina, Watertown, and Oswego. And they all have women's health, designated women's health providers. This is our new Women's Wellness Center, which was recently inaugurated by Senator Gillibrand. And this is our waiting area. And I think Mary has some more slides later on of the clinical space inside. Okay. I would like to give a historic perspective. So Women's Health Center on 2 East initially was founded in 1995, to be precise, for gynecological services and some primary care. So it started off as a very small program. And we had a contract with Department of Obstetrics and Gynecology at SUNY Upstate, off and on since 1990s, to offer gynecological services. But primarily the scope of care was very limited. It was primarily gyne and some primary care. And it has changed dramatically since then, as you would see as I go further in my presentation here. So the number of female veterans enrolled for primary care has at least doubled since early 2000s to now. There is also a significant number of female veterans who are using specialty services here in women's health. So we have gynecology services, we have female-specific urology services, we have behavioral health, mental health, and we also have clinical pharmacy services, which are all co-located in one location. We have significant increase in the number and the type of services that we are offering. So our number of patient encounters, I would think, at least has tripled, or maybe even more. So regarding the primary care, so we have PACT, which is Patient-Aligned Care Teams. This is another name that we have for medical home, that the word that is used in the community. Our veterans did not like that name, so we have PACT, which is Patient-Aligned Care Team. For comprehensive primary care. We have gynecology services, in which we have outpatient clinic services, outpatient surgery. We have major surgeries such as hysterectomies and many minor surgeries. We have urology outpatient clinic, outpatient surgery, again, major surgeries such as cystocele repairs and slings. behavioral health services, clinical pharmacy. We also have tele-women's health, by which we can do our appointments through a video call with the patient. We can connect to different community-based clinics and do video calls. We are hoping to be able to do it using iPads, and so that is under process. We haven't fully started that, but that is next thing that we will be doing with telehealth. Coordination of maternity services. Now we have quite a few women who are pregnant, and so we have to coordinate their care. Unfortunately, we cannot actually have delivery of babies in the VA. We don't have a neonatal unit, so we do send them out of the VA, but we coordinate their care. We stay in contact with them every 2 months at least, and we help take care of whatever medical issues they have during their pregnancy. So if they have a cough or a cold or an asthma attack during pregnancy, they come to us for that as well. Then a new thing that I'm very proud of is integrative medicine services. So we are starting that here now, which is unique to our facility. We are doing functional medicine evaluations. We are starting biofeedback, such as heart match technique, to help with stress reduction. We are using alpha stim for pain management. We have recently had some grants, and so we are using some of the grant money to develop our own library for our patients. So staffing at our Women's Wellness Center. So we have, for comprehensive primary care, we have a PAC team, which has a physician and a nurse practitioner. For gynecology, we have 2 part-time gynecologists. We have 2 part-time urologists. For behavioral health, we have 2 clinical psychologists who are working part-time. We are hoping to have 1 other person start in April. In clinical pharmacy, we have 1 part-time clinical pharmacist who does visits for us. We have 2 registered nurses, 1 LPN, 1 health tech, and 1 medical support assistant. Recently, we have had some clinical innovation and education grants. We have, at present, we're just finishing our Women's Health Specialty Care Innovations Grant from VA Central Office for $40,000. It was development of a multidisciplinary program for treatment of women diagnosed with fibromyalgia syndrome using patient-centered care model and principles of integrative and holistic medicine. We are in the process of collecting the data. It is very promising, and hopefully we will publish it. Educational grant from Waco, this was in 2012. So this was to offer a CME conference women's health education using different modalities other than face-to-face conference. So we were using innovative methods to offer education to our providers in the VA as well as community-based clinics, mainly because they had difficulty coming here for a full day of conference. So we would do noontime conferences using Microsoft Live Meeting. We were doing teleconferencing, video conferencing, and then we had 1 day of face-to-face. And it offered 26 CME hours. For education, we have medical students that come and rotate with us. We have medicine residents, internal medicine third-year residents, gynecology residents who rotate on our clinic. We have clinical psychology interns who train with us. We have had Women's Health Fellowship Program, 2002 to 2006. We have graduated 8 fellows from our program. We have peer education, and we have designated women's health providers and other primary care providers that we educate by conferences and lectures and other discussion groups. We also have web-based training, which is, we have Women's Health Mini Residency on MyVihu, which is one of our electronic university for education in the VA. In continuous improvement, we have our packed databases, which help us continuously improve our primary care services. We use that to improve upon what, how we are doing in clinical care of our patients. We have many lean management projects, including a project we are doing at present for improving diabetes education for our patients. We use patient feedback. We have a Women's Health Process Improvement Committee in which we continuously look at what problems we are having within our center, and we try to come up with solutions and engage our leadership in that. We have Women Veterans Health Committee, which is much larger committee, which kind of looks at overall structure of women's health program, not just the clinical care, but everything together, and we are all involved in that. At present, we have a gynecology flow team to look at our inpatient and outpatient services as well as our surgical services to try to streamline that. And I would like to end here. I would like to introduce Mary LaRussa. She's our Women Veteran Program Manager, and she will talk a little bit more about the overall program. Thank you.
Hi, everyone. I am Mary LaRussa. I've been at the Syracuse VA for 3 years. I am a family nurse practitioner specializing in women's health. So at the Syracuse VA, I have several different roles. I am a nurse practitioner in the clinic. I serve as the program manager. I serve as the weren't.
Sorry.
Good.
Yep.
There really wasn't a minimum standards across the nation. So what this guideline did was to put in place my position. Every VA across the nation has to have a Women Veterans Program Manager. There's a national database, so wherever you are, you can find out who has my position across the nation. And we are really responsible to make sure our facilities carry out those guidelines. We do represent a minority, even at our Syracuse VA, but at the Syracuse VA, we have worked diligently in making sure our women veterans feel welcome. If we have a beautiful new wellness center. You saw a few pictures. I'll show you a few more. But we are really committed to making sure that the female veterans at our facility feel safe, honored, and protected. So some of the principles of the policy. The first premise of it is that we want one-stop shopping for our females. So in our Women's Wellness Center, it's not just a women's health clinic, it's a wellness center. So it's comprehensive care for our women veterans. We don't want them to go to primary care. We don't want them to go to pharmacy. We don't want them to go to other specialty services when we want to offer it all in our clinic. And that is really important to our veterans. We're on the 9th floor for a reason. It's very private. It's very secure. They don't have to walk through waiting rooms. So that is really one of the principles of this policy. We also make sure that our providers throughout our VISN, which is Albany, Buffalo, Bath, Canandaigua, and Syracuse, are proficient in women's health. So there are minimum requirements that they have to maintain on an annual basis in order to be a designated women's health provider. And in the policy, it is specific. We have to have one, at least one in every community clinic, and we have many in our Syracuse VA. We're focused on safety, dignity, and sensitivity to gender-specific needs. And again, right place at the right time, and we really have some state-of-the-art equipment. So we reach out to providers who come to the Syracuse VA and our community clinics, and we find out who's interested in taking care of women, who's had previous experiences, and we want to welcome them, because not all our women are assigned to the primary care clinic. There's about 1,000 women upstairs in our women's wellness clinic, but there are probably 200 to 250 assigned in primary care. They've been there for years and they don't really want to transfer and leave their physician. So we reach out to all the areas. Again, full-time program manager like myself, we work very hard to talk about, we work on privacy, and I'll get to that in a little bit more, and I'll get to the chaperones as well. So some of my responsibilities, our position really looks at the comprehensive services. Are the services the same at Syracuse as they are at Binghamton, or as they are in Rome? So that's one of our overarching goals. I also participate in environment of care rounds. So every week there's a safety team that rounds on one floor of the hospital. We travel to each community clinic twice a year. I actually go much more than that. And we look at the space assigned for women veterans. We look at the bed placement. The foot of the bed cannot face the door. We really work on privacy. There has to be a privacy curtain. The doors have to lock. Providers have to be educated to knock on the door before they come back in. We really focus on their dignity. We also collaborate with OAF and OAF, military sexual trauma, homeless and minority veterans coordinators. So I work with those groups as well. They usually attend my committee and I usually go to theirs. And again, I know all the providers at our community clinics because we really do have a great working relationship. So our executive leadership, we work very closely together. They know all the projects that we are working on. For instance, yesterday we had a very successful Go Red event for women's health, and we had 200 people come to this event, which is huge. So our leadership supported that. They provided some of the funding for that event, so we were very appreciative of that. We work in collaboration with primary care. So my direct supervisor is the chief of staff, but I have to actually work with Dr. Langenberg, who is our chief of primary care. We establish minimum guidelines that we use to audit charts and different facilities to make sure that the guidelines are actually being enforced. And we do a lot of educational programs. Dr. Grewal and I have worked together on several projects, the grant projects, to make sure that we have education programs. So one of the nice things for women is when you come in for the first time, you get a 60-minute visit. Most visits at the VA are 30 minutes, but we give our women 60 minutes for the first visit. We also then schedule their next routine visit in 30 minutes. And an urgent appointment, there's a spot reserved for every provider every day. We already mentioned this, so all the care at the community clinics, they don't have as many services as we do at the Syracuse VA. We do have a family practice doctor in Binghamton. We have another one in Rome who really specialize in women's health care, so that is a great benefit. They no longer have to travel to Syracuse for routine things. But the other more remote clinics actually travel to Syracuse when they need to. Each of these facilities, and as well in the hospital, every single floor has a women's health liaison. So they get assigned, the poster is up on the wall, so patients and family members know who to contact if there's an issue with women veterans. So some of the preventive things that we are working on, the VA has probably the highest percentage of veterans getting screened for mammography. We're usually over 85%. In private sector, it isn't anywhere near that. So we really focus on prevention. So breast cancer screening, your pap smear, cervical cancer screening, colon cancer, and bone density. Our mental health is embedded right in our clinic. I believe they're also in every community clinic. We're working on getting specific gender groups together because our veterans are telling us they want to socialize, but they really want to socialize with veterans. So we are working on, part of our strategic plan this year is to get some separate gender therapy groups together. And we talked about the environment. I work very closely. Janice Kramer is a licensed social work, and she works in our BHOC, which is our behavioral community facility, and it's not on site. She and I work very closely when women are identified with military sexual trauma. We refer to her, and she takes it from there. So it's a great working relationship. Every facility has to have a military sexual trauma coordinator, so she's the person we go to. So Dr. Grewal alluded to this. There are 3 models in the national guideline that we follow. We are lucky we have 2 of the 3. So model 1 is just a general primary care clinic. So there's men and women assigned to the clinic, and the women's health care is in that clinic. Model 2 is where we were. It's a separate but shared space within an adjacent primary care clinic. And then we now have Model 3, which is the intent of the guideline, is to have an exclusive space just for women veterans, not associated with any other clinics. So here is our beautiful new waiting room. It has a fireplace thanks to Dr. Grewal, who has been the driving force behind this clinic, I must say. She has worked tirelessly for our veterans. This is our reception desk, and for the few veterans who are in here, if you know Penny, she sits right at that desk, and when patients come in, they want to see Penny. So we have a great staff. This is one of our exam rooms. You can't really tell, but the colors are beautiful. They didn't really show up in these pictures. This is one of our bathrooms, so I mean, the facility went all out. They're gorgeous. Tile. We had, when we opened the clinic on December 1st, officially, Senator Gillibrand came, and she had a brief tour, and she did a ribbon cutting ceremony. We've been officially open since the second week of September. I believe it was September 8th. That's our director, Mr. Cody. Emergency care. This is a very important issue as women are coming more to the VA. We have to have emergency room physicians, nurses, doctors, nurse practitioners, who are really competent in women's health care because we don't offer gynecology services after hours. So we really rely on our emergency room physicians to manage those patients until the next day if need be. So we have arrangements in place. We typically send our women to upstate or Krause because they're conveniently located next door. And again, we really work on the environment. We've talked about the dignity and privacy and the security of the rooms. So I also act as the maternity care coordinator. We have at least 60 or more pregnant or breastfeeding moms in our community. We don't deliver, but there are 2 VAs out west that deliver, but we don't have the census to do that. But we do make sure that all our eligible veterans get maternity care. So even if we have to see them and they're assigned to another clinic and they can travel down to us, we'll get their visit established so they can have maternity care. So what we want to make sure is that they ensure high quality obstetric care. I know the people in the community because I'm a labor and delivery nurse. I was also a women's health nurse practitioner. So I'm very familiar with the OB groups that we have, and we are so fortunate that 2 of the biggest groups have welcomed our veterans, and that is so important. They give the best quality care. I actually look at all the data outcomes. We look at premature birth, we look at baby's weight, we look at the APGARs, we look at the complications for mom, and we actually track all that. And the intent is central office research wants to evaluate whether female veterans are more prone to preterm birth, so that is in the works. We get every health record and we review it, making sure we understand what's going on with the veterans, because many problems in pregnancy carry over in primary care after they deliver. So if she has high blood pressure in pregnancy, she may have it chronically afterwards. So we have to be aware of that. And I function as the liaison with many of our local facilities. So an incredible package goes to every veteran who decides to breastfeed. She gets the top of the line electronic breast pump. She gets 2 nursing bras every year. She gets all the related supplies. This is probably the most excited they get. It gets mailed to their home. It's gift wrapped. It is a wonderful package. And I'm grateful to our prosthetics department for working with a contract person in Buffalo. So we all use the same organization called the Care Connections, and she's great. Approved services. We actually pay for the baby's first 7 days of life until they get their Social Security number paperwork going. We pay for their prescriptions. They usually have to bring them to the VA to get filled. And we pay for any kind of childbirth class they want, whether it's breastfeeding, parenting classes, nutrition, breastfeeding. We pay for it all. Yep. So that's it. I'd like to introduce Peggy Daggett. She actually is sometimes the first person a woman sees coming into the Syracuse VA. She is a nurse practitioner in the polytrauma program for our OEF, OAF, and OND programs.
Thank you. Like Mary mentioned, I am Peggy Daggett. I am a nurse practitioner with the Syracuse VA with the OEF, OIF, OND program, which is the Operation Enduring Freedom, Operation Iraqi Freedom, Operation New Dawn. Soon, hopefully, to be renamed the Transition Care Management Team, which will be way easier to say TCM. I also work in what's called our polytrauma program. Our two programs here at the VA are interchangeable. I am going to back up real quick and let everyone know I am an SU alumni. I graduated both undergrad and my graduate program in nursing here at SU, so bless you. Thank you. So our program is is a national program. What we do is we are responsible for meeting with all new post 9/11, those are interchangeable terms at OEF, OIF, OND, post 9/11 veterans that are coming out of the military or actually have been out of the military and are just accessing VA healthcare for the first time. We are their front door. So you could walk into the VA, walk up to the Veteran Service Center, say, I want to register. They look at your DD-214 and they say, which is your discharge paperwork, and say, you know, oh, look, you're a post 9/11 OEF, OIF, OND veteran. Let's get you up to the 5th floor and meet with our team. Our team is comprised of 3 clinical social workers. Lauren is our program manager, and then we have Greg and Bethany. Bethany is actually also our polytrauma case manager as well. We also have a retired Air Force veteran who is our transition patient advocate. That's Lloyd Collins. And what Lloyd does is he assists veterans who are being medically retired and getting out of the military. He's that connection between the Department of Defense and the VA, and kind of helps with answering questions for them regarding any issues they may have with that transition from DOD to the VA. And then we have our program assistant, Melissa, who is actually a Army reservist currently. She's been in the military, I think, almost 12 years. And she is the backbone. I joke all the time. Everybody will say, oh, you know, so-and-so is the backbone. Melissa is the backbone. She answers the phones. She directs traffic, and, you know, and she's key. And I am the nurse practitioner. So I'm the medical person who is there to answer all the medical questions. I do post-deployment primary care exams, and I do polytrauma evaluations. So, and I do some clinical case management for medically complex patients. So, in essence, that's our team. So when we're talking about female veterans, what we're on this group, we're looking at our OEF, OIF population of female veterans. And as Dr. Grewal had mentioned, this population has really grown. Oop, that is touchy, isn't it? Oop. There we go. So prior to 1973, there was a 2% legislation cap on female participation in the military. Once that gap was lifted, the entrance into military service for female veterans was huge. I mean, it was very significant. In today's military, 20% of new individuals coming into the military are female. 14.5% are active duty. Currently, 18% are in the Reserve and National Guard. And there is approximately 280,000 female veterans that have served in the post 9/11 era. This was some of the most interesting things I found when we were looking at this. This era of post 9/11 veterans has really yielded some pretty interesting monumental firsts for women. Admiral Michelle Howard is currently the 38th Vice Chief of Naval Operations. Admiral Howard was the first African-American woman to achieve a 3-star and a 4-star rank in the United States Armed Forces, as well as being, she was the first woman ever to achieve the rank of Admiral in the Navy. There are two other females who have also earned a 4-star rank, and that is U.S. Army General Ann Dunwoody and U.S. Air Force General Jeanette Hoffenberger. Jeez, sorry about that. So, who are these new veterans? Since 9/11, 1.8 million veterans have separated from the military. Over 60% of those veterans have obtained some sort of VA healthcare services. 61% were former active duty, 59% were Reserve and National Guard. And of these, 88% were male, 12% were female, and of all genders, 49% of them were between the ages of 34 and 44. So if you think about that, 49%, that's almost half of the individuals coming out of the military are between the ages of 34 and 44. So we actually have another larger population that are under the age of 34. So if we look at just 50% being in that era, it really is outstanding of the amount of people that we have in this military, of the OEF population, and that aged population. If people look at the VA, they assume that, we're looking at older veterans. And when we look at these numbers, it really does show us that we do have a younger population of individuals. In upstate New York, we have seen over 30,000 men and women of the post-9/11 era. Okay, the Syracuse VA, we are very close to the national average of how many women veterans that we see. We are currently at 11%, and the national average being 12%. Last year, the Syracuse VA saw over 3,500 women veterans, and of these, 2,300 of them were post-9/11 veterans. So that's just kind of a little age breakdown of where they are. So assuming that the 2,300 were under the age of 45 or 44 and up, that's where that 2,300 come from. She skipped one of my slides in there. Oh, well, that's okay. I'm just going to talk a little bit about the medical conditions that we see in our veteran population. There's 5 domains of medical conditions that all women are treated for, of the top 5, I should say, domains that women are treated for in the VA healthcare system are musculoskeletal issues, endocrine metabolic issues, 3rd being mental health and substance use disorders, number 4 being cardiovascular issues, and number 5 being reproductive health. And that's all veterans. That's just not women veterans. Currently, musculoskeletal, women are at about 56%. That is the highest of all female, of the top domain of medical conditions that female, or that all veterans are being seen. 56% for women, 48% for men. Of the OEF veterans, female veterans, musculoskeletal is right at the 48%. So that's still the #1 medical issue that women are seeking care for in the OEF population. The second condition that our OEF veterans are looking, that are seeking care for, is at 46%, and that is our mental health and substance use disorders. Pretty significant in this population of veterans. And our third is being reproductive health at 40%. When I looked at these numbers, and I apologize that the slide is not in there, but when we looked at these numbers, I had a comparison of males to females when it came to all veteran use of these conditions, and of all of them, women exceeded the percentages of all of these conditions of receiving care in the VA, except for cardiovascular. Men were higher in cardiovascular percentages over women. So when we look at those, and so looking at these conditions, it really does identify the need for evaluation and treatment targeting these areas. So we look significantly, even from the front door entrance, as looking at what type of services are these female veterans going to need to access, being obviously pain management services. If we're looking at musculoskeletal, we're looking at wellness, we're looking at weight reduction programs, we're looking at multiple areas within our VA. We have really exceeded in our pain management programs. We offer access to acupuncture, chiropractic care, Reiki, Alpha Stim, yoga. We have some groups through the Women's Health Program that have really focused on fibromyalgia. We have wonderful programs that really focus on the pain management issues when it comes to all of our veterans, but really focusing some specifics to our female veterans as well. Again, our mental health and substance use issues, that has been a key pillar of care for all of our veterans. And these new combat veterans, it really is a standout concern. And then obviously our gender-specific issues when it comes to female veterans, especially our OEF, OF veterans. They are younger, they are sexually active, they are involved with, you know, starting new families and new lives and you know, having babies and families. And a lot of issues, you know, come up that we find in our older veterans that isn't is prevalent. So how do these new veterans impact the VA? And we kind of really talked a lot about that already. But you know, so to the one area out of all of these is that our bullet number 3 it really stood out to me, and is that these young women that are coming into our VA. That are just returning from war, and maybe some never even deployed. They're still our OEF, OAF veterans. They are our era veterans. They may not be combat veterans, but they are our era veterans. They're going to be our lifelong VHA, or our lifelong VA patients. We've got them. They're ours, and we're going to maintain their health care, whether it's at the Syracuse VA or in Tulsa or in San Antonio or whatever. Our programs, the nice thing about our VA is that we're interchangeable. We can see records from every single VA, so I can take, you know, a female veteran that I started working with, and then Mary and Dr. Grewal saw, and we have our notes, and we've started things, and then they move. And these individuals, they are mobile. They move all over the country. And our VA healthcare system, our electronic record is phenomenal. I can go in and see when they've had, you know, physical therapy in one facility in San Antonio. I can see what this doctor said about this recommendation when they were in Washington. So it's everywhere. And we actually can see a lot of their Department of Defense records now as well. So to me, how are they impacting our VHA? They're increasing in numbers, and Fort Drum just announced we're just deploying again, so we keep making new veterans. You know, this country does, and we're just, you know, and they're making more female veterans. So, our VA is, you know, we're charged with making sure that we are providing the services that are going to best serve all of our veterans, including our female veterans. So, thank you.
We're going to transition to the next portion, and you'll get to hear from 4 female veterans. And I neglected to mention that at the end of the slide presentation, there's a list of resources available, and I understand the slides are available. I don't know if it's via live stream, but if you're interested in accessing the slides, there's a way to do that. So if the next panel would come up. And as they get set up, I will introduce the first female veteran who will be speaking is Shirley Edline, and she has an incredible history that I think you'll find as fascinating as we have.
I want to thank Dr. Heyman for inviting me today. I didn't realize that I was the token non-medical person. So you'll see a whole different point of view. Something I find very close to my heart and very important is that the woman veteran needs to know that she's not a first. It's important to know that many, many, many came before. Maybe nobody talked about it, maybe nobody knew about it, but that's what we're going to go through about 240 years of history for women warriors. This is me. I remember when I had been a school teacher for a couple years, I called my parents and I said, I'm going in the Air Force. My mother was extremely disappointed because she knew I would never come home and live in Dayton, Ohio with her again. And my father was a crusty old World War II vet who had fought in the Philippines, and his comment was, over my dead body, there's only whores and lesbians in the military. And you know what? My dad wasn't the only one that thought that. That is something that we have worked against for a long time. It's important that women veterans be seen as the warriors they truly are. I love what this one poster says, that she stands between the enemy and all she holds dear. And now, in 2013, the very first female soldier statue is finally on an Army installation. Unfortunately, it's at the U.S. Army Museum for Women. And it's still not out there as part of the combat. It's still part of a museum. But it's better than nothing, and it's all about changing attitudes. I hope the rest aren't like that. Since the beginning of America, women's been fighting. When we first started in 1776, and before that, when we were fighting against the British, we were called camp followers because we didn't carry arms. The military at that time didn't have a materiel command. It didn't have supply routes. It didn't have a medical command. It didn't have the people that were cooking meals that were wearing any kind of insignia saying they were part of the military. What they had were the camp followers. Those were the people that came along and they were expected to be the very best at what they did. They took water out in the field while the fight was going on. They took care of the soldiers when they came back wounded. They went out and got the food to feed them, and they cooked them, and they cleaned everything for them. And we, because of many reasons, people think that they were whores and lesbians, that that's just an old tradition that women are saddled with now. These two people, Molly Pitcher and Margaret Corbin, they have similar backgrounds. Both of them were camp followers. They had gone into war with their husbands during the Revolutionary War. Both of them, their husbands were killed, and they took over the cannon that their husband was firing. And usually what happened to the camp followers is they stayed with the military. They had no husband anymore. They had no family. The military had become their family, and so they stayed. Margaret Corbin in the Revolutionary War was the first woman to be given a stipend or a retirement pay from Congress. And Mary Hayes, often thought to be the real Molly Pitcher, was given a battlefield promotion by General Washington to sergeant. And she was given a retirement annuity of $40 a year from the Commonwealth of Pennsylvania. We got a lot to do here, so we're just going to kind of fly through this. The next thing we had that made a huge difference in how women were treated as part of the military was World War I. And as it says here from Winston Churchill, the amazing thing was how war changed. It had become a true machine. We had millions of people out there fighting and dying. And the weapons had become so huge and so intricate that there's no way that only men could be part of the military. They had to be built, they had to be carried. The sophistication of communications, if a man could fight, he needed to be on the front lines. And actually, it was, is this right? Is that the one I want? Well, I think it is. This is during, maybe we missed one. Yeah. The Secretary of the Navy, his last name was Daniels, realized that there weren't going to be enough men to carry on this size of a war, something that was considered a world war even then. And he went back and he looked at the congressional approval, and if that would be possible, decided it wasn't. So he reread the Navy regulations and found that a yeoman was defined as a person, not as a man. And at that point, he told the Navy and the Marines to start enlisting women into the military reserves because they would be needed. And during that time, we had over 12,000 serving as yeomen and Marines, and the Army had 230 bilingual women that were doing communications. In all, about 33,000 women served during the First World War, and 400 of them died in the line of duty. Jumping forward again, we come to the women's role in the Second World War. And if we thought the First World War was bad, the Second World War was bigger and harder, and we were fighting it on an eastern and a western front. Again, there's no way in the world that women could stay home. It just couldn't happen. Even FDR said that women gave their sons, and then they went to fight themselves. So many things people don't realize. There were 34 women air service pilots who were killed in the line of duty. And of course, they never had rank. They were never recognized for what they did. And these are kind of a collage of the women who died. During that time in 1948, President Truman signed the Women's Armed Services Integration Act, where it became a law that women were allowed to be in the active military. And I was born the next year. The women could be designated to certain jobs by their individual branches of service. The biggest part was that they were no longer considered camp followers. They were considered a true member of the military. Vietnam, everything changed. Everything changed. The funny thing is that there's statistics that we don't even know. If you ask how many women served during Vietnam, the number is somewhere between 7,000 and 11,000. Nobody's really sure. If you ask them how many men served in Vietnam, they've got the exact number. They know what jobs they had, what they did. And all of this is just because the time hadn't come where people looked at them and said, they're important. They have a right to a tradition. These are important things for them. About 80% of the women served as nurses during Vietnam. There it is. During Vietnam, I was a munitions officer, and I worked with a fighter unit, and we had rotations in and out of Vietnam every 6 months. Women served as air traffic controllers. They did communications, intelligence. They did the traditional roles of clerks, and yet they were out there. It was kind of like serving in Iraq in a way. There's no front line. It's just you are in the war. It is there. It is outside your door. And they're looking for you. There's nowhere to hide. So Vietnam made a big difference. Women in the military, I think for the first time, were really respected for being part of the combat picture. Now, just to kind of put this in perspective, at this time during the 60s, when things were really happening during Vietnam, the civilian woman at home had really not many choices. I graduated from high school in 1967, and I wanted to be a doctor, but there was no scholarship kind of funding for women to do that. During the 60s, 9%, or was it 6? 6% of the doctors were women, 3% were attorneys, and less than 1% were engineers. And the majority of women, only 38% of the women in the country worked at that time. The majority of the women were teachers, nurses, and secretaries. Nothing wrong with those jobs, it's just that not everybody wants to be a teacher, a secretary, or a nurse. Things changed after Vietnam. And I'm sure a lot of you guys here in the Maxwell Institute, you do a lot of historical things. You'll look and you will see that a lot of the anti-war movement was being run by women. They worked hard, they learned how to organize, they served well to serve their purpose. And when the war was over, they took aim at women's equality. And they said, you know what? We could make a difference there. So the military had always been the bullseye of the target, and it stayed that way. If the government doesn't allow women equality in the job, who will? That was the statement. And that's where they went. So suddenly women had a chance. We had a chance to fly. We could be, we were now going to be allowed on ships. We could be in combat to a certain point. Put it this way, we could be in combat, it's just nobody was going to know about it. That was the difference. The first thing that most people knew was changing was when Gerald Ford passed this, or signed this law that allowed women to attend military academies. And it actually took women going to court to force it before it was passed. And then they knew that it was really going to be out of their hands. They were going to have to let women go to military academies. And being at the right place at the right time, like I had been in Vietnam, I was selected as one of 15 to go to the Air Force Academy to become what they called an air training officer. When the Air Force Academy was created back in the 50s, they took junior male officers and trained them to be upperclassmen so that they could have an upper class in charge of the new cadets. When the women went to the Air Force Academy, they used that same pattern, and they brought in 15 junior female officers, and we went through training. 12 of us made it through, and so our job was to be their upper class. And it actually came to be more than that. This is going to sound a little crazy, but one of the nice things that came out of this, and no one really knew until it happened, was that it gave the male cadets someone else to hate. Who would have thought? We were officers, and yet we were invading their wing, their cadet wing. They didn't like that, and they resented us being there. They spent 6 months training us, going through all of the same military training that the women cadets would be taking. And so they learned what we could do and what we couldn't do. And just because you're in the military, you don't stop being a woman. So those are some things that they had to realize, is that you're not going to take a woman cadet and make her a man. She's a woman cadet and a woman officer. And praise the Lord, you can still be a woman. So they learned to hate us, and when the cadets came in June, the women cadets, at least they were cadets. And they had a camaraderie with them that they never could have had with anyone else, because they'd kind of gotten it off their chest by then. It was really a great thing that happened. The other military academies didn't use that pattern, and their attrition rate was much higher than the Air Force Academy. One of the big things, and it's just kind of a symbol of how things work in the military, things change very slowly. The words "Bring Me Men" was part of a poem, and the poem was actually about the Rocky Mountains. It wasn't about the military academy, but those words had been there for so long that they didn't want to change them when women came. And actually, it wasn't until 2003, the first women cadets came in '76. So it wasn't until 2003 that they changed the word, and it was, there were a lot of alums that thought that you never should change it, but it became integrity first, service before self, excellence in all we do, because that is the motto of the military, or the Air Force Academy. These are some really cool people. And one reason I've got them here is because I want you to see, when given an opportunity, how women can progress and shine. I don't think this country can afford to waste talent and intelligence. And it's important that we keep in mind that women have been part of the military, whether they were a camp follower or whether they're an astronaut. They have been there, they have a tradition, and they should be proud of that. Even though the rest of the world doesn't know it, the woman veteran needs to know her tradition. It's part of how you live. Janet Wolfenberger was in the class that I trained, absolutely brilliant, amazing, personable human being. She's now the head of the Air Force Materiel Command at Wright-Patterson. Michelle, the interest, I'll wait on Michelle, she's my favorite. Wendy, obviously, she's a class of '81, and she became an astronaut, and she did wonderful things. But the really cool thing about Michelle is that when she was at the Air Force Academy, she was the first woman wing commander. And the wing commander is not chosen for publicity. It's chosen because of respect and grades and a lot of other things. She was also the Air Force Academy's first Rhodes Scholar. And then she went back to the Air Force Academy and became the first woman superintendent of the military academy. And it's not that everything she did had to do with the Air Force Academy. She was also the commandant over at NATO's in Brussels for the Materiel Command for NATO. So she's obviously very capable. Welcome to Willie. This is pilot training. This is what's close to my soul. While I was at the Air Force Academy, there's nothing wrong with being at the right place at the right time, which is most of my military career, because women were just getting opportunities. When women started at the Air Force Academy, any graduate of the Air Force Academy has the right and opportunity to go to pilot training if he is physically capable. So what were they going to do when the women graduate? Well, they better start changing things now, because these women are going to graduate and they want to go to pilot training. And so fortunately, I was selected at the first board for women while the women were still at the academy, so they could test to see how women did flying. And actually, the Navy had already done it. The Air Force was kind of dragging its feet, because that's the soul of the Air Force. Hello, there. This is me. The reason it's there is because this was our patch. This patch was designed by one of the men in our squadron to show that it's the men and the women symbol, and that we are flying together. And it was really awesome. The men that they put in our class with us, because we were so, you know, they didn't know how it was going to work personally. They did. So they had us with a bunch of ROTC graduates who were not former military, so that they felt that that would be more appropriate for us, because we were all older. The age you could be was 27 and a half, and I was 27 and a half when I started. So I was really right up there at the age. Out of the 20 women that started pilot training, they divided us into 4 groups, and 16 graduated. Women now comprise about 14% of the active personnel. This is from a year or so ago, so somebody's got more information than I do. 152 female service members have been killed, and this was a couple of years ago. First Air Force Academy female cadet was killed. And before she went, she wrote a letter to her class saying how proud she was to be going to fight, you know, as part of her class. And it was kind of cool, because she saw it as part of something other than, you know, she saw herself as a part of something larger, something really important. I love this picture. The Air Force now has 85 female pilots, 2% of the total pilots. Finally, I think it's important to keep in mind that women don't want anything else out of the military more than men do. They want to be able to start out, get good training, work hard, and progress with their own talents. That's all they ask. this is one of the girls we trained, and I could not be more proud of her. And probably the final thing is that women in the military want to be respected, they want to be allowed to remain women, and they want to be remembered for what they did in their service. The government's not been good about remembering women's service and honoring it, and it will come with time. And without a chip on our shoulder as veterans, it'll come faster. One of the things I think someone told me once that she wanted is that all she wanted was for people to know that when some people stepped back when volunteers were called for, she stepped forward. And she was one that went to Vietnam. You know, and I think it's good to remember that women have always been and always will be a valuable part of our military. That's it. Oh, I'm supposed to tell you that Veronica Hamlet's coming up next.
Hello. First of all, I'm going to speak about vet centers, and then I'm going to talk about my own personal story as a veteran. So my name is Veronica Hamlet. I currently am the team leader at the Syracuse Vet Center. Right now, there are 300 vet centers located in the 50 states, including the District of Columbia, Guam, Puerto Rico, and the U.S. Virgin Islands. Our program began in 1979, opened up to Vietnam-era vets, and this slide talks about the, currently who we're serving after Vietnam. We started to work with Persian Gulf, Panama, Grenada, up to the new operation, the OIF, OEF, OND eras. So what we do at the vet centers, we provide free confidential counseling to veterans and their families. The recent legislation opened up our services to active duty service members who have served in a hostile environment, meaning they either deployed or in some combat operations capacity. We do bereavement counseling, and we offer services to victims of military sexual trauma. As far as community-based care, many vet centers offer services outside of the traditional vet centers. We go out into the community, we have outstations, what we call outstations. We try to reach the veterans where they are. Many are rural, and so that's a part of our mission as well. We also work with families, so family members are eligible. So when our service members come home, they may be having readjustment issues, coin the term readjustment issues, readjusting from military culture into the civilian culture, as well as post-deployment readjustment. So family members are affected as well. So we work with spouses, significant others, and children. Okay, so I just want to highlight on this. Our staff within Readjustment Counseling Services is made up of 72% veterans, and 41% of those are not of the 72%, but it's 41% of our staff are female veterans. And a large portion of our veterans are combat veterans. Okay, so this is our local vet center address, the Syracuse Vet Center on 109 Pine Street, and just some information about our local number and our website. So now I'm going to talk about my own personal story as a veteran. I grew up in Arizona on a reservation. I'm full-blooded American Indian. I am a member of the San Carlos Apache tribe. And My father is a veteran. He was a Vietnam era veteran, and my brothers also served in the Army. Both were Army. My father was drafted, and so I kind of followed in their footsteps to serve as well. I joined in 1996, went on to active duty, completed AIT and basic, and then I was shipped out to Germany. My first duty station was, I was assigned to the 1st Armored Division in Bad Kreuznach, Germany, and my unit was already downrange. They were supporting Operation, I want to say, they were in Croatia, and so I joined them downrange. It was S4 and I4, where they were supporting those operations. So I went downrange. I had 2 weeks to kind of orient myself into the unit, and then I spent the next 4 months in Croatia. We did convoys into Bosnia quite frequently. So it was quite a transition moving from coming stateside, and then within a few weeks I was, in a whole nother country, in a whole nother, serving in a different capacity. After that, I came back, went back to Germany. My unit redeployed, came back to Germany, and then they also came down on more orders to go back to Bosnia, which I volunteered for that operation. So I spent the next 9 months in Bosnia, and as a single soldier, just living with the challenges. I had an administrative position, working in an office, and also, doing collateral duties like convoys and just different missions. And so, so that was my deployment time frame. I served in Germany the whole time I was a single soldier, meaning I wasn't married, I didn't have any dependents. So part of being a female in the veteran, a female on active duty, and a single soldier, I had different opportunities, and I think that just being a soldier, I was afforded just different opportunities, which I later learned because I became what they called dual military. I got married on active duty, and so I was faced with a few more challenges. I got married and I had a family, and so my personal mission somewhat changed. I did move stateside. I was stationed at West Point, the United States Military Academy, or West Point downstate. And when I was there, the Army wanted to send me to Korea, and I came down on orders, and so I had to make a really tough decision to leave or stay, and I chose to leave, and that's how my personal kind of mission became my family. So I ended up leaving active duty, and as a dual military, my spouse was from New York, and I was from Arizona, so there was another tough choice that we had to make where we were going to live. And so I moved upstate to Binghamton, where I currently am now. And I've been there ever since. So my transition out of active duty into the civilian world was very difficult, leaving people I knew and served with, and the culture, having to find my way in a civilian world what I didn't have structure and rules, and so that was definitely a challenge. An opportunity that I had was I got to use my GI Bill. So I went back to school, I got my 4-year degree at Binghamton University in human development, and then I went on to get my master's degree in social work at Marywood University. And so that led me into where I am now. I've been working with readjustment counseling services since 2009. I started at the Binghamton Vet Center, and I currently am here at the Syracuse Vet Center. And it's my personal mission to continue to serve veterans. So that's all I have. Thank you. Next up is Kim Figueroa.
Hello, how's everybody doing? All right, I do not have any slides, but maybe I think I have my name up there, so, look, there we go, there's my name. I get the hand, oh, it's working. I just wanted to share with you a little bit about my military experience and my transition from military life, not just a job, but military life, into the civilian world, into the new culture. First of all, my background, I'm from a military family. My father was also a Vietnam-era veteran, combat veteran. So my whole life, I was raised in a military-like structure. As far as if there's any family members in the audience, you know what that structure is like. And also, thank you for your support. So I went from that structure, raised in that structure, into the military. I was in the Air Force, Security Forces, security police when I joined in 1994, transitioned to security forces in 1997. And it fit. It was wonderful. We had the three core values that Shirley mentioned earlier: integrity first, service before self, excellence in all we do. And it was something that my parents kind of instilled in me a little bit, while I was growing up. Those are very important. Those are the rules to how we do things, everything we do. And like I mentioned earlier, it's not just a job, but the military was a way of life. In addition to those core values for security forces, we also had general orders. All of the branches of service have general orders. From what I understand, some of them have, or at least one branch may have as many as 11 general orders. The Air Force Security Forces has 3. But those include, basically the rules about how we perform our job and what basic outline of what we're supposed to do. There was never a question about what we needed to do at any point, because we always had that structure, that outline. Here's what is expected of you. Work became my family, in addition to having a wonderful, supportive husband who was also active duty. But the people that I worked with were family members. They were the home away from home. They're the people that you turn to when you needed to talk to mom, and mom wasn't available, or dad, or whatever the case may be. So it's like having lots of cousins and siblings around you all the time. And also, in some places, I lived in what we call base housing, military housing, where other military families were. So my exposure was a significant portion of that was just other military families. So what was it like to integrate back into the civilian world when it was time for me, when I decided I was going to get out, which was in 2003. It was a huge culture shock for me. I got out and I'm looking for, core values in places of employment, and which are now referred to as mission statements. But I didn't know what a mission statement was. Excuse me. Sorry, I lost my train of thought there. One of the things that I found was that I found myself being really overly critical of this new culture, this culture that I didn't understand. Everyone seemed to kind of just move haphazardly, or so it seemed to me. It wasn't a flow that I was familiar with. it became very difficult for me to reach out to people. In my time in the military, my life was about guns, ammo, and training. And I didn't find a lot of women who wanted to talk about guns, ammo, and training exercises. It took me a very long time to learn how to talk about hair and nails and shoes. So my social life, it took took quite a bit of time to really develop and learn that it's okay to reach out. Something else that Shirley said that I wanted to talk about that helped me with my transition was really a change in my own attitude about things and looking at if these things, these core values and these general orders, this military way of life was what I was looking for, how can I find those things, translate that from what I'm seeing in the civilian world. And so that's what I started doing. I mean, it was surprising how long it took me to realize that I had the power to do that. It's kind of like the ruby red slippers there. Just click them 3 times and you're home. But the military, so I realized basically the military way of life didn't have to leave me. I just needed to learn how to make it work. And so it's still a work in progress, but it's getting there. It's wonderful. All right, that's all I have. Thank you. And next, I'm sorry, Dr. Jackson is next.
See if it's warmed up to slow down yet.
So I have a rather unique position, thank you, in that I make mental health house calls for veterans who otherwise do not have access to our behavioral health services. So as you might imagine, the mean age of my population is a bit older than some of the folks that we've been talking about today. Indeed, that age is 76 years old. So I'm working with a number of veterans, men and women, Vietnam era. We have a few World War II gentlemen and ladies still with us, gratefully. And I've also had the opportunity over the years, I've been working here at this VA Medical Center since 2009. I was at the Cleveland VA before that for my pre-doctoral internship. And since I've been here at this VA, I have had the opportunity to work with some of our OEF, OIF, OND veterans in Jefferson County, which Dr. Grewal mentioned, which of course is where Fort Drum is located. So that perhaps explains that large population of veterans that we have in that area. Thank you. Some of this will be overlap, I think, in terms of what we've already discussed, but I would like to bring forth a couple of points, salient points, that I'm not sure we have mentioned. Perhaps first and foremost, most importantly, is do we recognize that less than 1% of the entire population is currently serving in the military? That's 1% protecting, supporting the 99%. This is down quite a bit from the World War II era when that percentage was about 9% of the population serving in active duty military. And not just active duty, I should say, also Guard and Reserve, even if they're inactive. Nearly 15% of those, you've heard this statistic before this evening, nearly 15% of those currently are women, currently serving. And over 2 million now, over 2 million rather, of all living women veterans, yes now, all living veterans are women. Over 2 million of all living veterans are women. The Air Force, there are 3 out of the 4 of us are Air Force here. Kim, Shirley, and I are Air Force troops. Veronica is a diligent ground pounder, Army troop. Oh, there we go. Yes, how many Army people in the room? I always typically ask. Excellent. Marine Corps, I know Bob McLean is here somewhere. We have some Marines in the room. Yes. Navy. Oh, great. I had no idea. And Coast Guard. Coasties are hard to come by. Anyone who's in the Coast Guard here? We have one person I know of at VA. It's Aaron Russell, who's in Watertown, who's our resident Coast Guard veteran. All that to say, again, Air Force, in terms of women, for women veterans, Air Force has the highest percentage overall of troops serving. Marine Corps has the lowest percentage overall. Marine Corps is the smallest and most exclusive group, and they'll tell you that, right? Common career fields for women, as we've already discussed briefly, do still remain common career fields. So I was a police officer, I was a cop just like Kim. We're both security police, security forces. So we have folks in different areas and arenas, as Veronica was discussing, and of course Shirley was a pilot. But the common areas still remain medical, administrative, signal, which is communications, radio operations, intelligence, and supply. So folks ask us, well, why do women serve? Why do women serve? As we've discussed already today, for the same reasons that men do. These are the reasons why women enlist and become commissioned, some of them, some of us. Values, core values, duty, honor, integrity, code, respect, esprit de corps, and flexibility. I, too, was reared in an environment like Kim had mentioned, and Veronica as well. I suppose all three of us, all four of us, came from military families, where I was certainly raised with this sense of duty and honor, certainly for myself, and my own sense of self-respect, but also for my country, my community, my family, those that I can serve and give back to. My father, my late father, was a Marine. He served 2 tours in Vietnam, 2 combat tours. And I grew up in a lower socioeconomic stratum. I did come from a background where only one parent was even a high school graduate. Neither of my parents had been to college. There were not necessarily a lot of opportunities for me in terms of education, and I was aware of that from a very young age. So I'd never planned to go to college. I never thought that would be an option for me, which was fine with me at the time. So I enlisted at the age of 17, in fact. I left for basic training 17 days after I graduated from high school. Although my parents were divorced, they both had to sign paperwork for me to be able to go. So it was a pretty serious enterprise, this child. And indeed, remember who we're sending. It's children. We're often certainly young folks when we're enlisting, even today, being sent away to the service or having the opportunity to go away for the service. I, like Kim, I like what you were saying and pointing out about making order out of chaos. I was certainly rule governed. I probably still am. I liked that the notion of the military provides opportunities. If I make good on those opportunities, they will make good on their promise to me to, it's a reciprocal relationship. I serve them, they serve me as I serve you, my community. I was enlisted, I did two enlistments, so I stayed in for 8 years. I served from 1992 to 2000. I did finish a 2-year degree, an associate in applied science and criminal justice, while I was there for those 8 years. And then when I did separate, deciding that I was going to go to school full time, I did very well in the service. I was promoted early, made the rank of E5 staff sergeant, but I wanted to go to school full time, and I thought I was going to be a teacher. So 30 days after I separated from the military, I was in my first college class at a 4-year institution in Vermont, Castleton State College, where I'm from. And took my first psychology class there, and just, Judy and I are partial, sold, it's a done deal. And so finished my bachelor's degree there, and then received my master's degree and PhD from Texas Tech University, and as I mentioned, I completed my pre-doctoral internship at the Cleveland VA before coming here to work with you in Syracuse. So those were my reasons for serving, which really covers all of these bullet points. So the values piece I mentioned, career opportunity, educational opportunities are available for folks, travel. I was stationed in Florida, North Dakota. Why not, why not? It's freezing's the reason. It was 82 degrees below zero before a wind chill when I landed on New Year's Eve in 1992. And I was also stationed in Turkey, Korea. We all go through basic training and tech school in Texas. So these were wonderful opportunities that a person from Vermont may not otherwise have. Does everyone know where Vermont is? People typically ask, what state is that in? No, it's really, well, you're Northeasterners, so you get it. And then also insurance, and we've talked, some of the other providers have talked already today about these wonderful benefits and opportunities that we do provide to our men and women veterans lifelong. Don't assume that someone comes to VA because they have, you don't necessarily have to have a service-connected disability, for instance. Ask whether you or your family members are eligible for treatment services and supports at VA. Just come in and ask, and we'll let you know what you are eligible for, which does vary to some degree, of course, based on the person's experience, time in service, a number of criteria. It's always good to ask. Thank you. So one of the things we haven't necessarily talked about yet is that it's actually been, well, maybe Shirley, I think you implicitly discussed this pretty strongly, and rightfully, that it's actually advantageous to diversify the force. Right? And diversity has to do with a number of factors and descriptors, and gender is one of them. So if we diversify the force, we'll increase the chances of mission effectiveness by bringing a wider variety of tools to the fight, based on individual characteristics, based on individual attributes that apply to the larger mission, the grander mission. So that is to say, a more diverse force equals a more dynamic force, which is a more adaptable force. So this is from the German Marshall Fund, which is a transatlantic, you probably know about this at the Maxwell School, of course you do, policy relations group, especially involved in rebuilding areas post-war, post-combat, post-conflict experience there. And the argument here is, and I think it's a good one, and wouldn't you agree, that anytime we can get diversity on the same page when the values are shared, we have strength. That's across domains, that's across situations in our community, and we're certainly arguing that here for the military. So it's of benefit to have people of color, people of different cultural backgrounds, people of different socioeconomic status, people with different educational backgrounds, and people of both genders, or of different genders. Thank you. I am a clinical psychologist, so of course I would like to talk briefly about some of the clinical impacts that we do know, of course, and we do need to talk about these when folks have served. There are two major categories, naturally, mental health problems and medical health problems. So there are benefits, and then there are also, for some folks in particular, drawbacks. So in terms of mental health problems, there is the psychological trauma, not just necessarily the person may be combat, the person may not be combat. The person may have an identified traumatic experience or may not. But as some of the other ladies mentioned, simply enlisting in the military and then transitioning back out could be a traumatic event. It's certainly a notable event. Being separated from family and social support systems, being separated from your community of origin. Chronic stress, chronic exposure to mental stressors once folks are there. So again, remaining separated from family members or communities of original support, for instance. Stigma associated with seeking help. This is something that we do a lot of work, I think, at VA at normalizing and helping reach out. Of course, stigma is associated with seeking mental health services for all of us. All of us in our community, certainly as Westerners, there is stigma associated with seeking help, admitting to a mental health problem, acknowledging that you are needing intervention, but perhaps more so and above for military members who are supposed to be stoic and who are supposed to have grit and who are supposed to, we're told and we learn in the culture, to suck it up and press on. You know, why is this impacting you in this way? So there's another layer there, we think, for folks who are military members and veterans that might form another barrier in addition to the stigma that is so for everyone. There may be another layer there for military members in terms of the stigma that's associated with seeking help, which means the problem festers. So the problem may persist for quite some time before the person actually reaches out or we're able to get to that person. And the naturally medical health problems, which probably are more visible, wounds that are maybe more readily visible, blast wound, blunt, burn, penetrating wounds, amputation injury, physiological trauma, chronic exposure to this physical strain. I mean, just carrying the packs, how much does a rucksack weigh fully loaded? It's unbelievable. Are there any occupational therapists in the room? My OT is constantly saying, don't carry that, don't carry your purse that way. I mean, if you really saw the stuff that we had carried, an M60 weighs 27 pounds, and that's not to mention the second barrel and all of your ammunition, which when I was in Turkey was, I don't know, 750, 1,100 rounds. You do have an assistant gunner, but please, we're all loaded down with all of this equipment naturally, necessarily. loaded down with lots of equipment, jumping out of places we probably shouldn't be, crunching down into small places where we probably shouldn't fit. So these are all factors and experiences that, as we're going to talk about briefly in a moment, can lead to problems with chronic pain, other medical injuries, other medical concerns for folks that come about simply by virtue of their time in the service, or that they did serve. Separation from immediate health care. So when folks are downrange, we do have medics, we do have field hospitals, et cetera, but we're still separated from the main medical centers. I wouldn't necessarily say we're separated from quality medical care, but certainly separated from comprehensive medical care. Where there again, as we mentioned with the behavioral health problems, then the medical injury can fester, worsen, more than it would have if we were able to get that person intervention earlier on. And then also there is stigma associated, certainly in the military culture, to even admitting to having the wound. I mean, I don't know if you gentlemen who raised your hands who are veterans, or if I ran on a sprained ankle. I mean, we did that. You did that. That's what you did. You don't want to be the one who falls out, right? Because if you do fall out, by the way, in terms of the culture, running in formation, you can certainly fall out if you'd like, but the rest of the formation is not going anywhere. They're going to wagon wheel around and run in a circle until you're able to catch back up. So there's a lot of management from within. There's a lot of incentive, if you will, or maybe even fear of reprisal in the military culture to keep going. Again, back to that suck it up and press on, even medically. Briefly, you can access these data. We have a great hub website, va.gov. We have tons of wonderful websites, but if you start at va.gov, it'll lead you every place you need to go. Everything we've talked about here today can probably be accessed from that entry point. So these data are there. What I want to point out is that about half of people right now are coming back with chronic physical pain. So as I mentioned before, people crunching down, jumping out, strains, sprains. And so we're needing to, of course, manage those conditions. We can manage them medically, behaviorally, in terms of pharmacology, which we can talk about in the last bullet, might have a secondary implication in terms of what we're needing to prescribe and how we're needing to intervene. What I think is also important about this bullet point is if folks are coming back mainly, veterans are coming in mainly with, firstly anyway, and largely with chronic physical pain, who are they going to see first? Typically in terms of medical professionals. They're probably not coming to me and Dr. Heyman first. They're probably going to Dr. Grewal or other medical providers because it's a medical concern. And we need to be collaborating, as Mary discussed doing, with our medical providers so that we can provide them screening tools. When you have the veteran come in, he or she is complaining of a medical complaint, but we should be screening for behavioral health concerns at that point as well. We also know that folks, in the literature, we also know that folks are maybe more likely to, at least initially, be willing to talk with a primary care provider about his or her concerns over a mental health provider, at least initially. So we do need to be collaborative. We do an excellent job of that at VA. The data support that. Post-traumatic stress disorder. Most people don't come back with PTSD. I know that perhaps, or most people don't acknowledge or meet criteria. Doesn't mean that they don't. This could be a dark number. Maybe there are more folks with these conditions, and certainly the military sexual trauma. Maybe there are more folks than this percentage would suggest. But the idea is that it's not, quote, normal to experience PTSD secondary to a trauma. These are abnormal statistics. These are abnormal. That's what makes them disorders. Major depressive disorder, nearly 15%. This is for men and women, by the way. Traumatic brain injury, nearly a quarter, up to 23%. And then I mentioned the SUD, the substance use disorders. So I briefly touched upon perhaps, we do have some of our pain medications, some of our medical pain interventions, opioids, for instance. We do run the risk of the person developing a secondary dependence. Not only on the pain medication itself, but sometimes we have folks who maybe do have an anxiety disorder or depression and are inadvertently or unknowingly utilizing the pain medication to sort of tamp down or numb out some of the behavioral health concerns, other behavioral health concerns, where that's really not what that medication is indicated for. So we need to be mindful of that. I will also tell you, since you're college students and graduate students, newer data in the last couple of years in particular military people, active duty military people, active duty, not just veterans, not specifically veterans, are actually binge drinking and using alcohol at a higher rate than college students. So it used to be, right, you would hear about the college students, where are the party schools, who's drinking the most. Military members have surpassed the college student population at this point. That's alarming. And I'll self-disclose, when we weren't on duty, we drank. When we weren't sleeping, we drank. When we were hanging out, we drank. That's what we did. It's part of the culture. In Vietnam, some of my Vietnam guys tell me they flew in pallets of beer. We put cigarettes in the C-rats back in the day, the C-rations. The food, when my father was in, came with 3 cigarettes. So this is what we did. We did this as a community to ourselves, and so it's for us to partner and work through it together as well, in time. Thank you. Some differences in terms of, this is differences from men, women's service members and men's service members, and this includes veterans as well, as compared to males. Women are more likely to have some college education, have had some college work. Women are more likely to be commissioned. Shirley's the only officer on our panel tonight. They are more likely to be commissioned officers than men. They are likely to be younger in terms of a mean age, which some of the other women talked about. We know that women are more likely than men in the larger society as well to live in poverty. It's the same for our women veterans and military members. They are more likely to be Black or of other minority, racial or ethnic minority, and they're actually less likely, women, to be married than their male counterpart service members. So those are just some of the demographic differences. I think we talked about, some of the medical providers talked about some of the physiological differences for men and women. If we think, though, about that point I just made about military members drinking and binging to excess, we need to also consider how women metabolize alcohol differently than men. And I know that the medical folks can speak to that better than I, but we do know that we metabolize alcohol differently, perhaps based on fat content and just structure, physiological structure. Training, I would say, at least when I was in, now I've been out for 15 years at this point, but training was pretty similar. Of course, we're Air Force, we're military light. Is there anyone else Air Force in here? That's what we call it. We're allowed to say we're military light. But my training, I don't remember being separated from the men in any way, shape, or form. Indeed, when we trained for an exercise, full eagle, some of the Army folks may have gone with us there, full eagle in Korea, we trained together. When we deployed there, we were in a tent city. We were to be separated. We were told we would be separated from the men. There were only 4 of us, I think, in our entire, the squadron that went. And we said, would it be okay? I mean, if it's okay with the guys, it's okay with us if we stayed in the same tent. And we did. We had a little curtain that we put up, but we were in an open bay together, and we stayed there together. We trained together. Everything was very similar and the same. I don't know that that's the same across branches. I think there probably are different criteria that folks, ladies in particular versus men, may have to meet or not meet. Certainly body strength is different among men and women. You know, men might be as a group stronger, stronger than women across the board, whereas women are more flexible than men. So there are some differences that maybe some of the training does account for. Psychosocial differences, I think we talked about some of that. Certainly, we have a lot of single women everywhere in society, single mothers rearing children. Well, it's the same in the military. So the parents, if they're both in and they have children, I believe they have to be able to state where the children will go if both parents have to deploy. And then if the person is single, the man or woman is single, that person would have to designate, you'd have to demonstrate, right, somebody that you're going to have take care of the children. We already talked about career field combat. So we're not officially serving in combat yet, but we are. I mean, we're deploying with units, and we're defending perimeters, defending our perimeter to get our job done, whoever we may be and whatever we may be doing, which connotes becoming engaged in combat at some point. So, and we've been here all along, as Shirley pointed out. We already talked about, Judy had mentioned the VA motto. is this Lincoln right here? I was looking at this before. Yes, it is from President Lincoln's second inaugural address. I think we live up to this. We've been first or second in the nation at Syracuse VA in terms of patient satisfaction for as long as I've known about Syracuse VA. I mean, I'm glad to hear this year we're number one, or we're maintaining the first slot, but I think we certainly live by this motto, we live by this mission statement to care for, and as the professor mentioned, not only the veteran, but the family members, because this is a family affair. This happened to the entire family was involved. I mean, think about it, we have a term, military brats, for those children who did move around with their family, and it's adaptive. Children who moved around, right, may be more multiculturally savvy, often they're bilingual, so it's a benefit to move around, and it can be a benefit to move around in an intact family. Briefly, I'd like to touch upon some barriers there are to seeking help. So yes, despite what the media would have you believe that there's all these folks banging down our door and we're just not getting to them, well, that's not entirely true. I mean, we built it. Why aren't they coming? We're not necessarily getting everybody who would need, certainly in terms of behavioral health intervention. And there are some barriers that continue to come through in the literature. First of all, for folks who are on active duty or in the military, there are some positions that are highly sensitive. Kim and I had secret security clearances, or at least you worked with nuclear weapons? I did too. I secured nuclear weapons. That's a secret security clearance. I wasn't allowed to take NyQuil. I was an armorer at 2 of my bases. I wasn't allowed to arm people who were taking particular medications, and they were over the counter. So thinking about something like that, having you, we call it PERPed, or permanently having your personnel reliability program stamp or signature removed, think about what it would be to actually admit that you have a mental health problem, or that you have a drinking problem, or that you're needing intervention in some way. So this might be a barrier to folks seeking help. Could delay separation from the military service. So first of all, there might be an incubation period that happens where people are getting out and not necessarily realizing that there are problems that need to be addressed. But also, we're briefing people, but they may be, and debriefing people, and we have a transition program, at least when I was in it was 1 day. They may not be willing to state and acknowledge that they have something that they think might delay their separation from the service in terms of medical or behavioral health problems. Maybe unaware of post-separation services, although I think we're doing a much better job about that than we did perhaps in years past, educating just like we're doing tonight. Mary touched on this. We don't have this problem here, I don't think, or less so. Folks, especially women, must return to a co-ed military-related organization, and think about how that might be if someone does have military sexual trauma, or even not. Just returning to first of all, a paramilitary organization in and of itself can be intimidating. I've termed it returning for the healing to the entity that caused the harm can be a barrier to kind of get through, or sort of a confound. But also for women in particular, returning to a co-ed organization can be difficult. Mary is my provider. We've met, right? So I received my services also at VA, and I can certainly speak for how amazing the women's health clinic is. Even the old one, it just felt very private. There was a foggy door. I mean, it wasn't easy to get in there. It's just very welcoming, and it was away from the men. Cleveland VA, we had all of our groups separate in terms of behavioral health if women wanted to be in separate therapy groups, for instance. That opportunity is there. We already talked about the stigma piece, and then that reigning military cultural expectation of stoicism, which in a nutshell is the expectation that you will demonstrate significant patience and endurance in the face of harm and atrocity, or at least you will maintain the appearance of being unaffected. That can be a barrier. Even for the individual, I like what you were saying also, Kim, about getting out of military mind. You know, it took me a long time too, like, damn civilians. I want to go outside carrying anything in my right hand for like 10 years, because what if I had to salute? I mean, it took me a long time to realize I can go outside without zipping up my coat all the way and having a hat on. I mean, even small stuff like, seemingly small stuff like that can take some time to transition back through, along with these sorts of cultural expectations that are more salient, like stoicism. So in terms of wrap up, and we'll breeze through this, just in terms of review, be thinking about, for your lady veterans in particular, for our purposes here, the factors about her individual military experience which might continue to impact her today. And the only way you're going to find out about that is to ask and create that space for her to say. How her status as a military veteran might be an important and adaptive part of her identity. The identity that was shaping up for me when I was 17 was not a good one. I'll leave it at that. The Air Force made me. I'm so grateful to the Air Force. I know that wasn't everyone's experience in the military, but that was certainly mine, and it's an adaptive part of my identity that I certainly like, and I like to talk about it. And your veteran that God bless you, who's interacting with might as well. Consider, if you are a veteran, sharing some of your experiences and insights like we're doing here today with your friends and colleagues. What was it like for you? How would you recommend someone approach a veteran to open up that dialogue and that conversation, being a veteran yourself? Consider the language you're using and whether you're reinforcing. This is from our suicide prevention literature. I use it for everything. So my mean age for my population is 76. A lot of my gentlemen are, first of all, they don't need this mystical hoo-ha when the psychologist walks in, so we have to work through that piece. But then also, it's dignity. If he or she is in a place where maybe bathing on his or her own is not as easy anymore, I point this out. This isn't just in terms of reaching out for suicide prevention, but it does take strength and courage of a warrior to ask for help. I would like to help you like you helped us. Would you allow that? Okay, so consider reinforcing that. As we've already talked about, again, the camaraderie and sisterhood that is associated with the military culture and how this is expressed among veterans. Shirley and I have done 2 talks together now. I just want to keep doing this and learning more and more about our history, our standing history, that, as Kim and I were talking about before the event began, we weren't really taught a whole lot about that in the military. I mean, we learned about it after. We're learning about it right now. So consider for your folks or for yourself how the person understands his or her military culture, her in particular, and how this is expressed for her. How you can help reduce some of those barriers that we mentioned, and how you will respond, and you will be reminded. If you're not a veteran, we're reminded probably quite a bit. What would you know? You're not a veteran. And it's okay to say, you know what, I don't know. I'd like to know. Would you be willing to share with me what it was like for you? That's what I'm interested in. And last bullet here, just what we've done today. Just consider the face of a real-life woman veteran, which varies in terms of era, walk of life, background, experiences. Consider are there any other lady veterans in the audience? I don't think anyone else raised their hand. We're all over the place, though. There's someone close by, right outside that door. Consider how we cannot stereotype what a woman veteran looks like. Right? It varies. I do say thank you for your service because I am thankful, but more often I say welcome home, and I mean that for everyone, not just veterans who are in combat, but welcome home, and welcome home to VA. And we're right across the road, so let's continue to collaborate together. Thank you very much for having us.
We'd be happy to take questions. I think we have a few minutes. Anything from the live stream? Oh, yes.
Earlier you mentioned that you have some telewomen's services at the VA, and I'm curious about the reach of those services and the type of services you offer.
In telehealth, we have different types of services, like we have telewomen's health, we have tele-pharmacy, we have tele-mental health. So there are different types of telehealth services that we have available. So what we have at present is a kind of a video equipment that is there in the community-based clinics. And that equipment actually has like a stethoscope and otoscope and other things which can connect to it. So effectively, if I'm here and I want to examine a patient, say in Rome or in Messina, I'm able to pretty much do everything except touch the patient. So I can listen with the stethoscope to the heartbeat, I can look at the ear, I can look at the throat. So I can do kind of a basic primary care visit. I can actually utilize the nurse who is there in the room with the patient to help me with some of the other things. Can you please push here and see if it hurts? So it's quite things like, if I have to see someone for starting an oral contraceptive, if they're having problems, say, with hot flashes and they're menopausal, I'm able to evaluate that via video connection with the patient, so they don't have to travel all the way here for their eval. So that is the full-fledged service in which we actually have medical equipment which is attached to the to different community-based clinics. But the other one that I was mentioning was an iPad. So the patients have their own equipment, and we can actually have sort of a video connection on our computer, and we are able to have video connection and talk to them. So that is a different level of service. That is done more by behavioral health, because we have many patients who don't want to travel all the way here, for talking to the doctor. So they can do it via video, and it is secure. So there is a way to make it secure, because otherwise I think, why can't I just Skype? We can all Skype. So, but this is done in a way which is secure. But the other telehealth that I mentioned, that is like a full-fledged medical service. You can have stethoscope, otoscope, ophthalmoscope. So I'm able to do just about anything except palpation or touching.
Thank you, everybody, for your service. And Shirley, thank you for leading the way. It was very inspiring to see the history. But I read recently about the higher percentage of transgender veterans. And so as you were talking about gender-specific services, I wondered what you're doing to serve that population, or if you've anticipated that, if you're not currently seeing any.
So for transgender patients, VA has a national policy for transgender patients and how to manage them. And we have experts in every VA that are involved in continuous education so that we keep up with the current management for transgender patients. When they come to us, we've had a few patients recently that have had, say, male to female transition or like female to male transition. We have a process for that. We have primary care, we have endocrinology, we have urology, gynecology, all of them work together, and we have a structure for that. Okay.
I was interested that you said that you had women health fellows, and it seems as though the last year that you had that was 2006, and it seems as though certainly the expansion of the need for women's services followed that. So why not any more since 2006? And then secondly, and again, this is for anyone who feels they can answer it, women vets readjustment or transition, do you find that it's different for men, better, worse, sort of a summary statement there? Thank you.
I would like to start with the fellowship question, and I will probably let one of you answer the second part, the transition part. Okay. So the fellowship program was started, basically by our own funding mechanism within the Syracuse VA, and we were doing really well. We were having fellows all the way they were waiting 2 years in advance to get into our program. But VA Central Office decided that we cannot have the fellowship program unless it can be approved by ACGME. And Women's Health Fellowship did not exist as an ACGME certified fellowship, and it still does not. So there is no way we can use the GME funding for that, so we basically lost our funding because of a technical glitch. And we had a lot of people who were subsequently even contacting me because they wanted to do the fellowship. And there are a couple who are still waiting. They still contact me occasionally, and they keep telling me, when are you reopening your fellowship? So I'm hoping that we will be able to come up with some different mechanism of VA funding, which might happen. There are some VA-funded women's health fellowships. Most of them are research fellowships. I think there are about 8 of them nationally. We did compete in the last one, but we didn't get picked because Yale got picked. So I guess we can't compete with Yale as yet and Central Office. But they told us that they are keeping us in mind, and next time when they open up, we will be considered to have a different mode of funding. So it's just a matter of money. Yeah.
All right. In regards to your question about transition, it was regarding differences between transition for men and women, right?
If there's a difference, because I mean, I've known veterans, both male and female, as well as those who aren't in the military that have to transition into
Right.
new life.
I think, and everyone else feel free to chime in too, I think that it depends on the individual and their experience, their personal experiences, their background, where like Carolyn pointed out, there are so many things that factor into how we interpret those experiences. You know, so for example, you know, someone who may have been, for example, I was a tomboy growing up. I like doing those things. So somebody who was very much into, you know, like hair and makeup beforehand, may have just kind of jumped right back into that mode where, you know, I had slightly different of an experience in that transition. I don't know if anyone else has anything to, yeah.
I wanted to say something because I stayed in for retirement, and I was in for 22 years. The biggest challenge for me was that I was so identified with my career. And when I left the military, there was nothing out there for me. I didn't want to fly with the airlines. And so for me to have a position of responsibility again, where I'd, you know, been a flight examiner all over the world, and suddenly the best job I could get was data entry at the local college. And it takes a long time to find your personal identity as it is separate from your military identity. One thing I have found very good for me is that somebody at church once asked me what my passion was, and I said I didn't have one. But I did eventually find that my passion is veterans. Because so often veterans are the tail gunner, they're the lost ones, the ones that people don't know who they are or what their experience is, and they don't understand the challenges that they face every day. So I have been able to continue my work with veterans and continue my part of being involved in the military family. I'm currently my congressman's veteran representative, and I serve on the Academy selection committees, and I do tons of volunteer work, you know, for veterans that are just returning and veterans that are, you know, the few leftover World War II vets. So I think you don't really have to totally transition. It's okay to remain a veteran. It's okay to say, I'm part of that world, and I happen to be living in a civilian world now. And it takes time to find who you are.
I just want to speak a little to like post-deployment readjustment. So both our males and females face some of the similar challenges, such as leaving for deployment and coming back to picking up life where they left off. Things like whatever family situations they're coming back to, maybe even integrating back into like a social circle, children, so forth. Let's say they leave active duty and permanently, or even deployment, they're finding a new purpose, identity, employment, finding where they fit in. And so that's some of the challenges I think both male and female service members face. Do you want to add anything?
Sure. And just to add on to what Veronica was mentioning on post-deployment, in this area, and I'm sure it's in many areas as well, one of the differences we see a lot with post-deployment transition is when a service member has deployed to a combat zone and they're active duty and they return back to that military treatment facility or that post, and they're still in the active duty component, they've got the camaraderie of their soldiers, their airmen, their Marines with them all the time. In this area, we have a very large component of Reserve and National Guard, who when they come back from deployment, they are back into their their old environment, their home environment. So they don't have that, that battle buddy that they've been with for the last 12, 14 months to be there by their side. He may be or she may be in Texas or wherever, but they lose that. And I always bring back the fact that I had a service member or a veteran who came to me, and he had deployed. He came back and he said, Peggy, one day I was sitting in Kuwait on my way home from Iraq, and he goes, I had my weapon next to me, and it seemed like the next day, he said it wasn't the next day, but the next day I was back at Birdseye, and I was packaging frozen foods again, because that's where his job was. And he said, it was like that. One day I'm carrying my weapon, and the next day I'm back packing frozen food. And he said, that's the hardest part for me. And he said, it's just very difficult that I don't see my battle buddies anymore. I don't have that security of my people around me. And I think that's one of the things that we have, as providers in the VA, have to remember is we ask where you served, what branch of the service, but what did you do right after deployment? Did you, most of the time, depending, they're 30 days mainly that they're on active duty, and they're not with their buddies anymore. They're back with their families. So.
Well, I hope you'll join me in thanking this extraordinary panel. Thank you each so much for sharing your expertise and your stories with us today. We're going to have a reception right outside. Our guests will be with us. Please come enjoy a drink and a little treat, and there'll be a chance to talk to our guests. Thanks again for coming.